2020. It's episode 20 or 20 for a few good physios.
Champagne glasses.
We got to celebrate this one.
Yes.
We thought we were going to have one episode. Now we got 20.
Can't believe we did 20 episodes, but we're here now.
We're here now, and we're fresh off of a guest last week, which was awesome. Again, we want to thank Sarah Dimmick. It was a really enjoyable podcast, and we're going to have a lot more people like her on, including her partner.
Yes.
Talking about the positivities of good quality care and good quality training.
Yes. And, Sarah Corey will be joining us soon. Got the confirmation from that yesterday.
Nice.
But today's episode is a week in review, and we may play with the title, but we're advocating for some change that a segment of the industry is definitely moving toward. But there's another very large segment that is encroaching, and Lee has a good analogy of the David and Goliath, which has been posted.
Yeah.
So there's some interesting articles that came up on the New York Times in the last week, and it's the merger of Cigna and Express Scripts. They got approval from the Justice Department. That sounds very official. Very similar to another merger that happened earlier this year, which was Aetna and CVS. So basically, for those of you who don't know the companies, Aetna is a large insurance company, and they bought into CVS, which is a pharmacy / convenience store. And Cigna is also a large health insurance company. And Express Scripts is a large online pharmacy, I believe.
Yeah, I mean, in all truth, I skimmed this article from the New York Times, the merger of Cigna and Express Scripts, but you know, some of these things are hard to read, at least for me. But just to understand it a little bit, it's basically you take a health insurance company, and then you're going to take, I guess, a Express Script like pharmacy,
Right.
And you get those two together. So the ultimate goal would be to basically get drugs faster.
Get drugs faster, and also the pharmacy was getting paid by the large insurance company. So I guess the insurance company sees how much they're actually paying, let's say Express Scripts, and says, well, instead of paying them,
they're going to work for us.
Why don't we just own them? So
Right.
It's a bit of a, I mean, obviously the first line of this article, right, the title of this article, the approval of the Justice Department, part of the reason that is taking place is because there's a lot of monopoly and antitrust laws that I'm sure that had to be navigated.
Yeah.
If that's the word we're paid for. Yeah, I mean, it's basically they're buying a part of the chain, right? They're controlling where their money's going. It's going to themselves. But what it could mean for, I mean, this is a growing trend in the healthcare industry, as mentioned in the article, that, there's a lot of consolidations amongst these big, large corporations. And what that means for the customer may mean less choice or less, I mean, they'll have price control over these drugs now. So a quick little thing here says the acquisition would benefit customers by allowing the two companies to bring together patients' medical and pharmaceutical histories to improve treatments and lower cost. This is from the Cigna chief executive. The steps further our strategy to improve the affordability and the value to our customer in a more personalized way. So
That was a quote.
That's a quote.
Let me. Can you? How far do I
that
have to
will
go?
be in the third.
Oh, I got it.
Yeah.
Quality healthcare and competitive pricing for healthcare services and pharmaceutical drugs is critical to U.S. consumers. Wait, you didn't say that one. That was another one.
No.
Together, we believe we'll be able to. Blah, 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 blah. All right. So wait, how about this one? Together, we believe we'll be able to do even more to reduce healthcare costs, expand choice, and improve patient outcomes. Now, just break that down for a second. That was a quote by Tim Wentworth, the chief executive of Express Scripts. Together, we believe we'll be able to do even more to reduce healthcare costs. Just stop right there. Reduce healthcare costs. So if you want to reduce healthcare costs, what's the two major things that's happening to this country right now as we speak that's increasing our healthcare costs?
Not moving.
Not moving, surgery and medication.
Surgery
And medication. I mean, from our standpoint, we're talking, of course, orthopedic outpatient field, and you can even argue like cardiac surgeries, cardiothoracic surgeries, diabetes. You know, we're talking about billions and billions of dollars going in and out of our healthcare system every year. So by merging with a pharmaceutical express script company, I don't see how you're going to reduce costs. That's a misnomer. It's a false statement. It's a false statement. If you're going to really try to reduce costs, invest what's been shown by research to save money, which is conservative management, education, like you said, moving, exercise.
I think even in school, I recall when we went, we were just talking about note writing, but we took a note writing class of some sort in school, and they were like, be careful with the word prevention.
Yes, I do remember
Health
this.
insurance companies and Medicare.
Restoration.
So, so I mean, prevention is a huge. That I think is a cost. Now they may have, I don't know if any healthcare companies have done wide scale research on the cost benefit of prevention, but you know again, Lee and I are a bit jaded on the topic. Just because we know what the benefits are, and we truly believe in those benefits. But, yeah, I don't understand how a healthcare company merging with a pharmacy pretty much is going to reduce costs.
And so reduce healthcare costs. The next part, expand choice and improve patient outcomes. This is a loaded friggin' quote, but this is going to go into one of my weapons that I see that people like this are using. This euphemistic language and this language of confusion and this idea that things aren't happening. So this unacknowledgement. So expand choice, what Eric just said, like this most likely will lead to less choice. You're now combining two companies into one where they can control things and basically just give you one choice. Like if you look at that movie, Wall-E, we talked about it before. Do you remember the theme of the movie? It was so far in the future. There was just one company that ran everything. It was like a big and tall company or something. It was like the equivalent of Costco.
Right.
And they just ran like food and medicine and spaceships and all this other shit. That's the same thing that's happening. This whole idea of, we're just going to monopolize everything and they're just going to become one gigantic company. And then there's literally just four stupid old white guys sitting around a table and be like, we're going to make decisions for everybody and get ourselves some new boats.
Yeah, like, there's a lot of boats being purchased after this. But, I mean, to be fair, it is a trend, right? So the article goes on to kind of talk about these other similar relationships. CVS and Aetna, we just mentioned. Optimum RX is now owned by United Healthcare. Aetna operates Blue Cross Blue Shield. So, you know, these mergers are pretty much an industry norm. But, you know, the Justice Department is a little nervous that all of these are happening pretty soon, pretty a short amount of time.
They accepted it. They accepted it. And then what are we talking about? 62 billion? 50-something billion?
52 billion.
I mean, there's no way in hell, like, these massive amounts of money are so hard to even, what's happening now is, like, more and more of these deals are occurring and somewhat under the radar. Obviously, this is an article in the New York Times, so it's definitely not under the radar, but who knows what's being negotiated right now, what's going to happen in the future. And people who get affected are not going to be them. I mean, they're going to be reaping the benefits. Everybody else, including the patients and, let's say, conservative management therapists, doesn't have to be just physical therapy. There's all sorts of other conservative management therapists out there, occupational therapists, chiropractors, DOs, all these other people. They are not going to be reaping benefits. They'll probably work against them. But
yeah, it's very interesting. Again, this is a bit of a norm, but it's it's coming to light, and I'm not sure how the public will or will not react. Often these kind of things go under the radar until you're in a position that you need healthcare services, and then you realize that it's kind of shut down. I'll just show you this that I highlighted.
Oh. Yeah, and that's happening already.
Yep, exactly. And it's in the paper.
Right.
So, something that this is another, on topic in the article. The article goes on to say that in January, Amazon, JP Morgan, and Berkshire Hathaway announced a plan to team up to address these healthcare costs that are spiraling out of control. So they're going to try to create their own little kind of in-house healthcare to their employees. So we'll keep that on the radar. It's very, very similar. I guess the only benefit is they may be doing business from a different perspective. But it's yet to pan out.
I just wanted to read a paragraph here. I'm just scanning this. Rising drug prices are forcing the issue for the insurers, said Terry Stone, a managing partner for Oliver Wayman, a consultant. Many were unprepared for the onslaught of new, very expensive medications, she said, and were, quote, caught off guard, end quote, when new hepatitis C drugs were introduced a few years ago at a cost of tens of thousands of dollars to treat a single individual. So I'm getting from this paragraph that they're saying that this deal would reduce this.
In theory, I don't know.
That's
all in theory. And then the way it seems to work is if they're a larger company and they have the backbone of a health insurer, they have more leverage with the pharmaceutical companies, which do business very, very ethically correct. They do it by the way.
But that doesn't make any sense to me. What is the theme with insurance companies? What's the theme? Like, every year do your premiums go down? No, every year they go up. I mean, they go up. We get less and less services for the more premium. I won't name this person, but I know somebody who was on some health insurance company, and it literally doubled that following year, the exact same plan. I mean, how sustainable is that? It's not, they had to get off of it and be on Cobra for a while or whatever it was, and that's like $500 a month in its own. But it's just that this doesn't make any sense to me. That's like basically saying it's like the whole crazy definition. You do the same thing and you expect a different result over and over again.
And again, as some people in power have said, it's a complicated issue. It's hard to put your finger on, like, point the blame, right? I mean, is it the health insurance company just making sure their profit margin isn't affected? Is it the pharmaceutical companies that are pushing their prices, which is making some healthcare insurers non-competitive? Right. Is it healthcare providers or hospital institutions that are charging $500 for an aspirin? So there's not, just to be fair, it's hard to point a single finger, but the truth is that these mergers kind of, I'm not sure how that's going to benefit the general consumer, the person looking for the, quote, health care, because it's really not health care. We were talking about sick care, right? This is really sick care, not health care.
Correct, yeah. I mean, sicker and quicker, all that stuff. And I agree with you. No, I 100% agree. I could sit here easily and just start pointing my finger and naming names and blame people and blame companies, but the real thing is, like, all this stuff is like taking towels and try to, like, stuff a leak in the ceiling, but nobody's going to go up on the fucking roof and see what's causing the leak. So what's really causing the leak is this mindset of Western health, like this, this lack of education, this misinformation. It's all, that it's gaining profit margin on one end and then not giving information to help people actually become healthier with all this, technology and research and things like that.
Yeah, and I think, as a physical therapist, as a trainer, for those of you who may be listening, it really starts with one person, right? One patient, one client. And I do believe in the power of kind of a domino effect. That person has now improved their well-being, their health, and may pass that on to someone within their circle. Right. So, I mean, as frustrating as this is, as a provider, I don't like that word. As a physical therapist, as a trainer, as frustrating as it is, I am optimistic in at least the work I do, along with the people that I'm around doing the good work. So, but there needs to be more of us. There needs to be an army. Well,
that brings us to our next point.
The next our next metaphor analogy, I'll let Lee take it on from here.
So I'm going back and forth how much I want to go into this, but in general, and we've talked about this so many times, advocating for change. No, I think the majority of physical therapists they don't want to hear this. They don't want to, like say anything too much, because if they look too upset and whatever, then they might not get what their reimbursement rates are like. The insurance companies might be upset if they have their own business. God knows what. I don't know. But that's not helping us. What's not helping us is just sitting back and complaining about it. One of the reasons Eric and I started this podcast is we had information that we wanted to pass on to people. And we did as much as we could with patients, one-on-one, and our colleagues and stuff like that. This technology of having a podcast is huge. We can have a lot more people listen in, and it's fine. They don't agree with it or whatever. But the people who don't know this information, they learn it, and then they make changes. That's great. That's what we want. This is what we know what we can do. And there's some other things that we have going on in the background that we're trying to work with, or projects and things like that. We're not just sitting here talking shit through a microphone. We're also trying to do other things on the outside with major institutions like schools and stuff like that. Definitely students and new grads. And
mentorships.
Yeah, so like all these things. But I do have to say, those who are out in the field right now do realize this. It's a problem. This is not normal how things are operating in the physical therapy world. It's not. So as great as our associations that are trying to do certain things, they're not kind of hitting the point where separating themselves from what is the problem. Like right now in the orthopedic outpatient world, the mills that do not perform physical therapy and just are a lesson in billing and ultrasound and just doing this cycle of whatever you want to say, documentation, and then churning people out, turning people in, that's not helpful. And connecting with those mills is not helpful either. So supporting them is not great. So one of my biggest thing is, you want to advocate for change, you want to elicit change, then you have to get out of this circle that's happening, or there's usually a rhythm that happens, and you have to get bumped to get out of the rhythm to get into this next circle if you want that to happen. If you don't want it to happen, just friggin' stay there, complain every day, be miserable, be burnt out, whatever you want to do. I mean, I see this all the time.
Ultimately, what I've been saying this for a while, but you're letting other people decide your career. I mean, your quote autonomy isn't really existent, and I think as I've come to realize over the last 5 years, that there are other entities that are now controlling our industry, right? So you went to you made the decision to go to graduate school. You got a license. You took the boards. You're gung-ho about quote helping people, but you have other corporations, organizations, lobbying groups, whatever you making decisions that will affect your life, will affect your salary, will affect even your patients' outcomes. I mean, so there's a lot that's going into it, and I think one has to know all these things and make your own decision. And Lee said, if you're okay with that and just want to show up to your job, that's fine. But know that you're not. Yeah, you may not be working to your potential. Let's just put it that way.
Yeah. And this is the best time now than ever, because we have evidence. We have research. We got a large group of people who are advocating for these changes, and they're not part of big associations. They're just on their own individually. They're from other countries. They're from here. There's many people doing this. This is the best time now than ever. So you can contribute in that sense, spreading the word, trying to influence other people and how to educate other people to maybe even start cash-based businesses, educating people on pain science, exercise, strength and conditioning. These are things that are, if you bullet point it, are going to push us forward. So add a network cash-based business, strength and conditioning knowledge and expertise, use that as a skill set. Pain science, that is not going away. That's going to lead, if you look at the big picture, that's going to lead to some change, because that directly goes against this model is that I have to perform some passive modality on you and you're going to get better and you're broken and you're, need to be fixed. No, it actually empowers the patient. It educates the patient. It gives them tools that they can take care of themselves, and then they can spread that knowledge. They're more likely to take care of themselves, less likely to have medication, less likely to go get surgery, elective surgery, imaging, all that stuff. So this is something that, although we might be sitting here bitching about things, we are trying to give actual skills to make a change.
Yeah, I think a lot of new therapists, and even old, feel somewhat beaten on this because the idea they feel that there's a lot of barriers. There's a lot of barriers to doing exactly what Lee said. There's barriers to trying to promote exercise. There's barriers to trying to work for a cash-based business or starting your own business. There's plenty of barriers for that. One mainly being fear, but yeah, there are certain financial there's a lot of barriers out there to making the jump. But knowing the other side exists, and also knowing that working toward that however you can, whether that's working part-time on top of your full-time job to work on your own practice. Maybe that's taking Con Ed to try to improve your skills so that you could prove yourself in a different domain. So there's definitely ways out there, guys, and again, the barriers are really self-created because, again, if enough people make their own path, then the system kind of changes.
Right.
But right now, there's a lot of complacency, and it's part of we've discussed this at length, and I'm making a huge assumption here, but the kind of personality type that kind of goes through with physical therapy, that gets into the industry in general, is one that thinks of helping and typically is an optimist, I would say, and just doesn't think about the other moving parts aside from what's managing their career, what's influencing their career. And unfortunately, there just needs to be more people. It's just a volume thing.
Yeah. I just wanted to bring up real quick about other professions that we can learn from. So we've discussed in the past chiropractors. Nothing bad. We know so many chiropractors who do very great treatment, and they're very knowledgeable, very skillful clinicians. And of course, there's the opposite. They're not great. We hear about it from patients and doctors and other chiropractors. But we can learn from them. They have completely separated themselves from the, quote, Western medical community and been able to get the practice rights to do things such as order imaging. Some states apparently get prescribed medication, anti-inflammatories, or whatever it may be. They're not really limited by insurance when it comes to how many treatments they can treat somebody by state by state. Like, we have direct access. The insurers are working their way around that for sure.
Right.
Every day, every mid-year, there's always some new policy from other insurance companies. They're like, oh, well, now you need a prescription for that type of plan inside that insurance company, so direct access doesn't apply. Really? Okay, I've been practicing for 8 years, and you still need a prescription, but we're, quote, direct access. Anyway, so that doesn't happen in chiropractors. So how did that happen? They got together and they lobbied for change. And they had lobbying power. They had financial investments, but they went in the right direction. So, like, when this whole new thing with Aetna came down, where we posted about it recently, some associations weren't like, no, let's challenge that. They were like, let's make it easier for them to implement this, and we'll, quote, educate our physical therapists to implement it even easier. No, we don't need to get educated about how to implement it easier. We need to figure out why they're doing this, and if it doesn't match up with how we can give quality care, then it shouldn't happen. And we should say, like, no, we're not going to do this. We're the one providing this care. We're the clinicians providing this care.
Right.
So no, I don't want to. And this week, man, I had Blue Cross Blue Shield, I had Aetna, and I had every day was like, well, this note needs authorization. This note needs authorization. Holy shit! Like
More do you see that as a trend? There's more.
just this week, like
Right.
I had. I mean, today's only Tuesday,
Right. Feels.
and I had.
It was like a week.
Yeah, I mean, I just had a lot of evals. I guess it must have been last Thursday and Friday. Sorry, last Wednesday, Friday, and then Monday. So, it was starting last week. So, because I think that the onset date of all this was September 18th, if I educated myself correctly and read those emails. But that doesn't help me. This doesn't help me. Because I could spend that time emailing the patient. Emailing, because I had to make a choice. I remember yesterday, I was like, do I email this patient their home exercise program and the information I went over them today? Or do I have to, before 5 o'clock, do I have to give our billing department the note to get done? And at the end of the day, I'm not going to have time. Right. I'm not going to have time. And we don't get paid enough to have an assistant sitting next to us and writing notes. And that if we get enough reimbursement rate, to hire an assistant, yeah, we could have. Fine, I'll if you give us enough, then I'll get an assistant, and they can write the note. Have whatever friggin' policy you want, then I can email the patient.
Yeah, I think what this all boils down to is this authorization process and these changes, these policy changes. How does that really affect patient care?
Yeah.
As Lee clearly stated, I mean, it's basically going to be a choice between documentation and patient care. And unfortunately, you might not even have the choice, because if you choose the patient care, you may not be able to care for the person too long because they'll get denied.
Yeah.
They're not going to get treatment. So, yeah, are these policy changes, are these mergers beneficial to the person in the middle, which is the patient, right?
Right.
And it really doesn't sound. I mean, one of the most frustrating, I guess, parts of our job is documentation. And I understand the benefit. Excuse me. I understand the benefits / the necessity for documentation. But what we're discussing now is not documentation. It's basically authorization from another person that's most of the time non-clinical entity. They may have, quote, clinical help, but we all know that that's,
they're motivated by everything else.
Right,
I mean, clinical help.
They're like, it's a biased.
The more you deny, the more money you'll get.
Right. Like, and we don't know that. We don't know that, but it appears that way.
I know that. No,
yeah, right. We have the inside track. But they're never like, all right, person has lower back pain. You know what? Just let me know when they're better. You know what? You're good. Just keep treating this patient.
I totally get that. I totally get it. And Matt said it when he was here with Jordan.
Having that
the limitation. I get it. It's that I'm totally fine with that, and I'm totally fine documenting. I think it's just it's gone the other way. Like this,
right.
You meet a lot. Observing behaviors is what we do for a living. So a lot of the, quote, burnt out therapists that I view very close in my environment, I see the same themes. This absolute obsession with documentation and the frustration that they get when their work put into the documentation does not pan out for visits. No. And that totally makes sense as a human being. Like you do everything right and you document this person's dysfunction or whatever it may be, their medical necessity, and they're like, yeah, just 2 visits more. That's all you get. And then you're like, why would you document again like that? Why would you, why would you feel good about doing that? Obviously, it's our job to do that legally. We have to. I get it. Yes. But what I'm saying is what they're looking at is not necessarily in the same mindset that we're looking at. What they're looking at is, all right, well, they have this plan. Their pain rating is a 4, not a 5. We really need that to be a 5. Their range of motion, I didn't even really look at that. But their outcome measures on something that I don't even relate to is really high. So they're not going to get any more visits. No, they can't even fucking walk, and their range of motion is severely limited, and they can't do the things that they love to maybe keep themselves healthy. They can't lift their baby. They can't go work out, when they go work out, that's what their doctor told them to do to keep themselves healthy. And if they didn't work out, then their blood pressure goes up. Then they're going to develop cardiovascular disease, and then they're going to be more stressed out. They're going to drink more alcohol. Then they're going to get
This is all
fatter.
because of you, big company.
But like,
all because of their authorization.
right? It's this stupid circle that they don't understand. It's not just about that flash number. Great, good for you for being able to say they have not a high pain. Their outcome measure is great. Good for friggin' you. What about the person? What about the person? Why is that person coming in to see the therapist? And the therapist, 9 times out of 10, they're gonna write why they're coming in. They're a nurse and they can't do their job. They're a father and they can't lift their kid. They can't play with a kid. Read that. Read that.
Well, maybe, I think the call for change here would be into looking, what are we looking at when we're, quote, when the insurance companies are authorizing visits, right? What are they looking at? Now, we know the pain is not objective and that number gets played with. Yeah. We know that, some of these outcome measures, although valid and reliable, really mean nothing in the real scheme of things, right? Yeah. And often patients filling out these outcome measures say, well, what? This isn't relevant.
They get really
right? This isn't irrelevant. Can I comb my hair? The person might be bald, like myself. Things like that. Or can you walk? Can you walk 3 blocks? That might not be relevant for someone in Texas.
Running. Can you run a mile?
Did you run a mile?
I have patients who get so upset about this. They're like, I refuse to answer these questions.
Right. So, again, the call to action here is, what can we do differently, I guess, as a field to really push the idea of what are we looking at, and why don't we look at things that are relevant to the patient's life? Yeah. The patient, the real reason they're coming in, right? Not all these objective measures.
Well, they essentially want as many numbers as possible to manipulate. We've seen it kind of firsthand. We're kind of behind the curtain. And one thing that companies love, corporate companies, they love stats and numbers.
Data.
They love data, and they bring in these people, and they pay them a lot of money to bring them in. They just read a bunch of data, and these people who are not clinicians, they're like, well, this number says this, and this number says this. In about 3 months, it's going to say this.
Right.
Great. So what if their utilization went down in July and August, and it went back up in September all the way to December? I wonder what the fuck happened there.
Maybe people went on vacation.
Yeah. So find out a different way to make money. You're a big company. You can make money in all sorts of ways, and you have like a whole friggin' social media department. You guys don't even have a friggin' Instagram account. Like how anyways, so they love data. They love data. And why don't we look at examples of people actually doing this, countries that are doing this? They're in Australia, Canada, New Zealand. There's people there who are bringing this information to the forefront, and they're affecting as much change as possible. And they're getting written up in these big articles, big journal articles, things like that. And they're trying to show, like, we need more information on the patient side versus these numbers to treat the patient effectively. And we need to give more information to the patient. And to do that, we need to educate them. And to educate them, we need to sit down with them.
We need time.
We need time. You see what I'm saying?
Time. And when the person's filling out that objective measure, and it's like, what? I haven't ran in 30 years. I don't have hair. All this is time wasted from actually looking at your patient.
Right.
I had my primary care doctor, I think maybe 10, 15 years ago, during a checkup, asked me, I was talking to him, and he was like, my apologies, I gotta write my notes on this computer. Due to legislation, I need to document everything electronically. Unfortunately, instead of looking at you, I'm now looking at a screen. So I'm actually missing certain cues that I normally would have picked up, but my face is now. This was 15 years ago.
Mm-hmm.
So fast forward to 2018. That's one of my pet peeves is when someone is doing an evaluation and they're not looking at the patient but writing their notes, which they're trying to be efficient, and I understand that, but. Mm-hmm. I think, it's a perfect example of how technology is actually pulling away from patient care, right? Yeah. So sorry I went on a tangent there, but I'm trying to express that, the requirements don't match the service.
Right.
And again, the data, we know firsthand that data doesn't always equal reality.
No, and that was another thing.
And interpreting the data, I believe, should have someone that understands the field, not someone that understands finance.
Right.
Although the financial aspect is critical, we need to put the lights on. Someone that understands what it is to be in the trenches, to be treating X patients a day. That's my opinion.
100%. I agree with you. There was that one, there was a discussion when we had some managerial responsibilities back in the day about like extra, so I'll just say it, bonuses for like an increased utilization. And they basically they had some really interesting ideas, which none of it made sense. It was kind of like this out of craziness thing. And we made the simple suggestion. Why don't you accurately track where patients come from other people? Like, I treat Harry. Harry apparently feels better and is going back to what he's doing. He tells Sally. Sally comes in and says, I heard that you can help me, and blah, blah, blah. Track that. And then you can give out, if they hit a certain number in a month or 3 months, whatever it is, then you can give them a little bonus. Because what that means is that they're building trust. They're building that relationship. It's such a simple friggin' thing, too. They couldn't even do that. They couldn't even they still can't do it.
Yeah, I think, that the idea of bonuses is industry-wide, right? And usually it's based on utilization and or the amount of people you see, which makes sense from an owner's perspective because you're going to have people incentivized to see more people. But the question is, does it incentivize them to perform quality care?
I have a question for you, and this is a question I wrote down here. Is a better therapist the one who has a higher utilization?
Negative. No. I wouldn't equate those two because often it's a personality type that, knows utilization revolves around some kind of reward system, and they become driven to that number, not necessarily care. They don't equate. No.
Yep.
I've known many high volume therapists that are very busy, and they make a concerted effort to keep their schedule busy, but they treat it so subpar. So, no, I don't think so. And, the more is not the better, obviously. I mean, no.
But companies look at it like that is the better therapist. Yeah. And we can easily bullet point what you just said.
And the good, I would say, to be fair, the therapist is an income-producing therapist. And that's, listen, I get it. I would love to have a high-earning therapist on my staff, which I don't have. I have a staff of one right now. But yeah, I understand that, but not at the quality. Now, on the flip side of it, if I did hire someone that was, quote, really busy, but doing shoddy work, I think that's a huge risk to my business, right? So, no, I mean, look, the numbers don't relate to quality.
Right. And by the way, we've been on both sides, and I'll say that right now. There have been times where I was extremely utilized, if that's the way to put it. Like
utilized,
I was 100% utilized
right,
for a long time, and I was probably a worse therapist in those times because you don't have time to write notes. They don't give you time to write notes, and then you have to do all these other tasks when you work for those companies, and you're going from one patient to the next, and you have to deal more with this patient came in late, came in early, this canceled, all this little game that every physical therapist has to play.
It's a time management game.
Yeah, and it wears you down. And luckily, I was somewhat young when that was going on, and like right now, I'm pretty utilized, but I'm nowhere near like
It sounds horrible, man. I'm sorry. We're gonna have to change that. I don't want to say. He's productive at where he's at, and that's cool. But he's not utilized. Because he's utilized.
It is a terrible thing to say.
Yeah.
That
and provider. Yeah. No, provider. You're a high utilization provider, a.k.a. you make someone else a lot of fucking money.
No, it's true. It's true. And
man.
I had a patient the other day. He actually emailed me. and he's super nice, and he's like, I hadn't seen him for years. It was a patient who treated previously and been discharged, whatever. And he's like, "How you doing?" All this stuff, and he's like, "I'm seeing so and so therapist from your referral, because I can't see you right now." And he's like, you did such a fantastic job. I really hope you're, what did he say? Basically, I hope you're appreciated financially from them, like to that extent. And I was like, not really, but that's fine. But
No, it's a tricky thing, and I've learned this. I think early on. I mean, I think the start of our physical therapy careers, and I realized that there's no way. When you're working for someone else, the ceiling is always going to be a little close. And I think I had an idea like, oh, I'm an asset to this company, and I have so much to offer, and without me, blank, blank, blank. And I came to realize that we're all somewhat dispendable, and if I wasn't there, then 20 other people can be there, and you just realize that when you're working for someone else, that you're always going to be working for someone else. And again, there's a margin in which they're able to you pay your own salary, and you pay your own benefits, and then they take a little off the top to provide this quote stability of a job or career. So I think all of that is a fallacy because there's no real security. You could argue that it's a relatively low risk situation, but in essence, it's a high risk situation because you're potentially losing that earning power if you were on your own or partnered up with other individuals. That being said, at the end of the day, if you're working for someone and it's grinding on you, as it always does, just again, explore those options and think of the barriers that are there. Some of them are quite real and some of them are perceived, but that's my rant.
Yeah, no, I totally agree, and I think if you're still listening to this one, because you might have stopped a while ago.
Wow, they sound angry.
Yeah.
Oh God.
Well, that's the other thing too. Like, this is not out of the norm. I hear so much crap from PTs all the time. We've been treating for 8 years. Everything I just said previously, everything Eric just said, it's nothing new. Nothing new, and it's been said a lot worse than what I said and what Eric said. So we're just expressing regular things that happen. I guess when I see people who are really visible, social media, journal articles, whoever it is, they're very political. I understand. I get it. But I do think we need a little bit more energy. And you don't have to be contentious, rude, whatever it is. You could just easily, intelligently say with a lot of vocabulary what we're saying here and advocate for change. It's still a possibility, and we try to do this every day, and we're doing it with patients, and there's a lot of stuff that it's amazing. When I talk to patients, I had a patient the other day, treating him for his elbow right now, and he's going to come back for his neck and his back. He's got all sorts of issue. We had this conversation about Tiger Woods. And because Tiger Woods just won a really big championship. So he was like, oh, man, he was going through so much stuff. And there's this great podcast that I can't remember the name of it, but Peter O'Sullivan, which we mentioned him so many times before. And he was a guest on this podcast. And they asked him back in the day after Tiger was going through those initial issues with his back, about information. And Peter O'Sullivan is armed with all this incredible research. And, of course, his decades of experience and doing research himself. I mean, he was like, he said it perfectly. But with the absence of neurological symptoms, he definitely went down the wrong path. Oh. Multiple surgeries, medication, all this stuff. In terms of if he had education or if he had the right people next to him and being like, well, you should go down this path, you could probably avoid these surgeries because you don't have these neurological symptoms. And we're not talking about pain down the leg. We're talking about frank motor weakness. We're talking about, bowel and bladder dysfunction.
Tripping over yourself.
Yeah, those serious things. Pain is a different story. Pain is extremely complex. We talked about this so many times before. That's why you have to go see a really skilled clinician, whoever it may be, that is going to have the information to discuss it. But my point was, having this conversation with the patient I was treating for his elbow, I gave him it's like a sprinkle of that stuff. And he's a very educated person. He owns his own business, very nice guy, and he was just like kind of shell shocked. He's It's like, what are you talking about? Like that.
I had the same conversation this morning.
Yeah, so I ended up sending him a bunch of information, and he was very appreciative, and you know, his relationship, him and I is very good. So, but that we're trying to do that on a small level. I mean, that is what needs to happen to affect change in our field, in the medical community here in the West, on a large scale, large scale change.
No, I had the same conversation this morning with an older client of mine. He said, "Oh, what do you think? That's a great thing. You know, Tiger Woods came back. You know, from what do you think of those surgeries he had? You know, he had a fusion." And I said, "Well, you're asking the wrong person." And I said, I was like, you know, I don't know his condition. I don't know exactly what he was going through, but I think it's an overutilized surgery, and research is coming to find out that many people do worse. And it's exactly what he said. So I know a couple of people that have had this surgery, and they're not any better. If anything, I think they're a little worse.
Right.
So why would they do that? And I said, that's a good question. So I explained to him a fusion. He was like, why would you fuse? You know, this is an older guy with no experience, right? And why would you fuse the discs together? And I said, well, in some extreme cases of a traumatic injury, like burst fracture of your spine, different. Like if you have a fracture in your spine and you're unstable, or you tear a few major ligaments, and you have a bone that's just floating around in your spine, different story. But we're talking about lower back pain. Something that affects 80% of people.
90.
Look at that. The numbers are going up. I remember saying 3 out of 4, 80%. Now I'm going up to 9. 9 out of 10 people will have lower back pain sometime in their life.
Oh, yeah.
Right? I mean, I had it
just
last
interview
night.
5 people.
My back is hurting right now. No. But this gentleman was like, why would they do that? He was just stunned. And I was like, it's a Band-Aid, and it's an expensive Band-Aid. And I think people want immediate results, and unfortunately, it's mismanagement. And I think at some point, maybe we'll look back and it may be negligent. That's a very loaded word, and I use it freely, but
I agree though. I 100%
there's
agree.
a lot of, and again, we are biased for conservative management, but as research is now proving, and it'll be on the show notes. This
is going to be a picture of me really angry on the show notes this time. I'm just going to be like,
ripping off his headset. Oh man, no, it's wild. But the Tiger Woods, I actually told the story about when we were in graduate school and we did the skit on Tiger Woods.
oh my God, that's
That was
right.
crazy
Jesus, we had
stuff.
the skits.
Yeah, man. At one point, poor Tiger had a cervical radiculopathy.
That's right.
And there was question on how it occurred, whether it was his ex-wife or there was a car accident. I don't remember the specifics, but it was.
Well, he had both.
We had both. We played it all out, and we had a video from an Asian news station, which I'm unclear of, and they gave a whole animation of how it went down.
I remember that.
How he got
gotta
injured.
Look that up.
Yeah, we got to look that up. But
That's
it was funny. But it was funny how, again, people hear Tiger Woods spinal fusion and say, "Wow, must have been bad."
It must have been bad. And I heard that again from another client who was like, "Yeah, he had so much pain, he couldn't stand up, couldn't play with his kids." I mean, we are not trying to downplay what he was going through.
We're clueless. I personally, I'm clueless. I know Lee, you don't know that. We don't know the specifics.
Not his clinical information. No way. Like all I know is this information from articles. But this is not an uncommon thing. I mean, that's what happens when people have injuries to your back. Like you go through these cycles of pain, then you should get everything ruled out. You should get the big stuff ruled out. Fractures, a neoplasm, a growth back there.
Cord compression.
I mean, we know we've seen patients with basically a burst fracture, L1, L2, from serious trauma, and they had to get fusion, and they had those serious things. They were paralyzed from that part down. But that's where fusions are medically necessary, and that treatment that stabilizes the joint and prevents further spinal cord injury. But fusions in general, as the NIH now has deemed, it's not going to be normal practice act for non-specific low back pain, which sounds like what he had. I mean,
Yes.
maybe unless we're missing something clinically and they didn't want to release it, fine. But he didn't have this frank motor weakness. He didn't have quad equine syndrome or bowel and bladder dysfunction. That. So when you read those things, for the person who might not know, it might shock them. Be like, "Oh, wow, he had something serious." That's why it warranted 4 back surgeries and medication and stuff. Well,
4 back surgeries.
it's pretty
Poor
crazy.
guy.
And it's good for him. I'm very happy for him that he won the most recent thing. That's hard to come back after 5 years. That's very and an injury.
I was talking to my client this morning about this, but he was a pioneer in the sense in the golf, I guess the golfing game, where strength and conditioning became a thing, which seems like, he had that part of the picture where, he didn't just play golf. I mean, he had a pretty extensive, and I don't know the specifics of it, but he was one of the first golfers to really popularize strength and conditioning.
Yes.
So it's cool to see that. Yeah, it was cool to see him at the top. He gave a good emotional speech. I saw a little clip of it. But good for Tiger. I'm glad he's had a turnaround, and hopefully he'll never have another surgery.
Yeah, no, I hope he's getting right management. It's interesting, though, when you look at people who are at the top and they have a fall and they come back. I think that's one of the most, it's very, that's a very challenging thing to do. You really have to kind of hunker down and work hard for that.
Yeah, it's cool. Again, very, very inspiring, and we wish him the best.
Yes. Going back to the, just kidding.
No. Go. Yeah, we gotta talk about this association.
Yeah. Well, yeah. So the idea that best interests are in mind when it comes to associations, it might not be the case. I mean, this is why I'm trying. I think we're both trying to give more information to the individual clinician, because the more you can learn about this information, the better. So like this whole Aetna thing that happened, if you don't know what it is and you're a clinician, they basically are, it's not just plan specific. It's every plan under I think both Aetna and Blue Cross Blue Shield, because it's both, or
for what?
For the pre-authorization stuff.
That's a tough question. I'm not sure, actually. The pre-auth, I think it was just Aetna on this particular one. I think that was a major shift in September. And again, it's a tricky thing to get authorization when you haven't even seen the person.
Right, yeah. So if you don't know what that is, if you go for physical therapy, that first appointment's going to be covered just because it's the eval. But what the insurance companies want in this situation, when they need, quote, pre-authorization, physical therapist sees them, they document, and then they send that note along with a prescription. And if the prescription is needed, I think that's plan dependent. And outcome measures, everything's looked at. Some magical person that's floating in the air says, oh, they get 12 today, they get 6 today, or whatever.
Now, this is another crazy concept that probably hasn't hit, but in the may make a little difference in the out-of-network world. Getting authorization before you see the patient.
What?
Yes.
When did
this
start?
Is pre-auth. So before the patient
before
comes
the
in,
eval.
Before the eval, you give a diagnosis. How? I don't know. The only way this works is if you're getting a referral from a doctor who has a predetermined. This doesn't work for out-of-network, right? I mean, excuse me, for direct access.
Right.
So they will cover you at a certain rate if you don't have pre-auth. So they might not give you the full reimbursement because you didn't get authorization.
So you're getting financial benefit
from just saying,
seeing
hey,
the doctor.
For seeing and for saying to the insurance company, hey, I got Joe coming in tomorrow. He sprained his ankle. He sprained his ankle 2 weeks ago because they probably want a date of injury, right? Mm-hmm. Just giving you the heads up, Joe's coming in. And that's enough. That's pre-auth. All right, Joe's coming in for his ankle. You cleared it with me. Then they may require auth, right? After that, after the first visit, you'll say Joe's ankle range of motion is decreased. It's swollen. He can't walk. He's limping. Then maybe, but like you said, I don't know this goes to the authorization police or department.
That's insane. Or what gets me the most is obviously they're trying to do this to, quote, control costs.
Correct.
Okay, great. So what research shows that this is what's costing the health care world more? Like
I
seeing
think it just comes to what we always discuss. It's another it's another little hike. They could turn around and say, listen, look at the policy. We require pre-authorization. Therefore, we're not going to cover those first 2 visits when you didn't contact us.
Mm-hmm.
So we'll start fresh. Those 2 visits you'll have to eat and pay your light bill some other day. So I don't know. So it's crazy. But my understanding, from what I hear, is they're getting overwhelmed with all of this, because this requires a lot of manpower. So this auth and no auth and members benefits, they're probably spread a little thin. So I don't see.
They should just get rid of it.
They should just if it was that easy, that would be nice.
I mean, I do. I mean, my thing is, I guess what drives me the most nuts is like when you hear all this stuff and then you hear about like when we're presented with research that's showing conservative management is going to save the healthcare world, whatever. And then you talk to people and they're just, they regurgitate the same information. I'm like, why can't you just like take a step back and look at what they're doing? Like it's just common sense stuff. It's any person, any adult, they could just see what's happening. It's another barrier to prevent this conservative management from being initiated and from going forward successfully, whereas where insurance companies really make gains is on the other side. Imaging, medications, surgeries. That's the money. I mean,
that's a tons of money. And again, is that being scrutinized? Are these? I mean, I do. To be honest, I know that a lot of imaging insurance companies do require authorization for a lot of imaging, and that's another catch, right? This person needs an image. The quicker they get the image, in some cases, the quicker the course of care could be determined. But there's holdups. So this person now with the ankle sprain that they're not walking around on thinks they broke their ankle. They're waiting a week to get an image, a picture of their leg, a little picture. They're missing work. They're not getting treatment because, let's just hold off on physical therapy, which we know is a bad idea. Let's hold off until we get the image. Everybody's on hold. And then the insurance company accepts it. They get the image. And now it's 2 weeks, and now the person's been immobilized. They still can't walk. And now their rehab process is now extended. So, again, I'm not sure there needs to be some clinical eyes in these decisions. And I think they're out there, but they have to be a stronger voice.
It does. So this is the conundrum. This whole idea, PT first, get PT first, right? There's this whole hashtag thing on Twitter, and a lot of the leaders, they're pretty funny about going against it because then they'll just launch into this whole like mill situation where not all PTs are great, which is absolutely true.
This is
absolutely true. We see firsthand, we hear about the horror stories from patients. So there has to be some sort of verification or like vetting or whatever it is, or something that is really a little bit more aggressive in, hi, I'm a PT. Okay, well, I think you're going to need to prove that a little bit more in a sense that, this goes back to supporting the mill situation. So are you going to be that one? Are you going to be that group who are okay with just doing, churning these things out and, providing this low quality care and just focusing on your documentation and not getting educated?
That won't help the patient. That'll reinforce the fact that the patient was like, well, I tried PT.
It didn't work.
It didn't work, so I went to the doctor, and the doctor, he ordered an x-ray. He gave me an anti-inflammatory, and I feel so much better.
Mm-hmm. He gave me an injection.
He gave me an injection. He rubbed my leg. I don't know, but but again, the mill situation is not good for any of us in the field, right?
No.
And low quality care, also a big determinant in how people perceive us as a whole.
Right.
So
So that needs to change.
that needs to change.
And this is what I was bitching about earlier and whining that this needs, this is not helping us.
Lee's going to drop the mic. I'm fucking done.
I talked about it before. Like, I've had my moments, you know that. And it's tough. And I think I am obviously not alone. I hear this stuff from 100% of the PTs that I know that I'm an acquaintance with. And I guess that's hard for me because I know these groups of people can get together and we can really affect things because we're the ones providing this stuff. We're the clinicians in the trenches. We're the ones getting our nose bloodied every day. And I know it's dramatic, but it's true. We can say like, no, we're not going to pre-authorize this. We're going to treat the patient. We have the skills. We have the tools. We have certain tests that have higher ratings in terms of percentages and statistics that are better than imaging and doctor's examinations. That's just true. Right. That's just evidence. I'm sorry to say the scientific method, this is we can put that in the show notes.
Right. And I think as Lee just called to mobilize everyone is like, I mean, I don't want to get too specific on this, but the idea of kind of creating another organization is not too far off because the split is kind of happening. People that are being, I mean, complicit is a big word. I know that Lee likes that complicit. I mean,
think it's perfect.
No, it's complicit. I had to Google it, and then if you look at complicit,
what does it say?
It's to agree with some kind of illegal activity. I'm going to give you
That's perfect. That is unbelievably perfect for the situation because
I'm trying to be diplomatic, but it is true. No. I think you're right.
See, Eric is a really good friend, man. I'd be lighting the table on fire if he wasn't
complicit, involved. All right, look, involved with others in illegal activity or wrongdoing. Okay. So that's but I think that people are complicit, and I think again it is a person. I personally think it's a personality type of not wanting to ruffle feathers and really kind of going with the flow. And it's a large institution,
Yeah, and we have to get over this. We are the institution that's doing this.
You are your own company, and you are your own representation. So what you do on an individual level with your patients, it matters.
Right.
It matters because that interaction you had with that patient for whether it's 20 minutes or an hour, whatever it is, that first interaction, the second interaction, whatever experience that patient has is now what they think of as, quote, what a physical therapist does.
Yes.
Or what a trainer does. And, I think we all have a large, a big job, really, in kind of promoting the profession in the most positive way, and ultimately that's quality care, and we could talk about quality care and how that varies person to person, but really, I mean, each of us can make a difference.
And it was interesting recently. There was a in-service done that I witnessed, and it was a fantastic in-service, and it basically was given to some seasoned therapists, some new grads, and it was about common myths in our industry, and it was just basic stuff we've already talked about. We're talking about the myth of bad posture, the myth of tissue damage equals pain, the myth of this incredibly intricate physical examination is going to determine the outcome of care and or the injury. For instance, if you examine, like someone has shoulder pain and you're measuring the millimeters of the medial border of the scapula from the vertebrae, and that really makes a difference of scapular dyskinesis. That's like an actual diagnosis. So all these things, and it was not well received. It was not, and sadly, the most seasoned of all these therapists was probably, actually, this is not surprising, but it was sad to me. He was very, I don't know what the word is.
Confrontational?
Confrontational.
Or maybe dismissive.
And both, and angry and all these other things. And it didn't get through to him. And he just refused to accept or even learn more about it. And he actually, pulled a new grad aside who wasn't doing the in-service. And that new grad had a question and was trying to get more insight in it. And he basically was, after the thing was done, he was trying to tell her that this is, no, I don't remember exactly what he said, but the theme was this information doesn't really mean that in the case of like other things. And that's really sad to me because that's a new grad. And it's like depending on how much respect that new grad had for him, who knows how much information got through.
Right.
But I wanted to say to this person, like, you're going to be a dinosaur. You already are a dinosaur. You're a dinosaur, and dinosaurs are going to get extinct in our field very soon. And it's not a theme. It's not my personal bias against this person.
No. It's
gonna happen.
It's happening as we speak, and we talk about this. Look, people are realizing, well, my shoulder hurts, my back hurts, my knee. It's probably because I'm out of shape. People have that thought, right? I'm like, I have patients that come in and say, well, I gained some weight, and I think the weight is affecting my knee now or my ankle, whatever it is. So these patients are going to say, you know what? I don't really need a doctor. I don't really need a physical therapist. I think I'm going to get a trainer. And there it is. The dinosaur is using ultrasound, telling them that they have, patellofemoral tracking issue or whatever it is, and escape the fact that this person is a bit out of shape. And the trainer is going to be gun-ho, enthusiastic, happy to be with this person. They're not going to have to write a note. And they're going to make this person feel better. And then that dinosaur is now on its way to the pit.
Yeah, and this dinosaur is getting, it calls out sick and has back pain all the time, and I would say, wow, I mean, like you're a living example of what we try to instill the patients that we want them to avoid, where they can manage the stress appropriately, they can handle their body and the information that's going in and out of their body intelligently, and you can't even do that, and that is no surprise to me that you have this mindset that's not going to help other colleagues, other people, whatever it is.
Yeah, if there's one piece of advice to any therapist, physical therapist, trainer, whatever it is what Lee's mentioning about perception. I mean, you could mobilize someone's knee, you could release somebody's hip, you could help them out with, glute med strength. But if you could change their perspective, then you're able to help them. And a lot of, with pain science, we know that what often takes a person to kind of feel better is a shift in mindset, perception, and just the way they experience, the way they perceive what they're feeling and how they're feeling it. So, I mean, aside from any fancy clinical tools, changing someone's perspective, and we're not asking them, to change anything that they're morally hold tight to themselves. I mean, we're talking about orthopedic issues here, right? We're not asking them to change any political affiliation.
Religion.
We're just, none of that. We're just, hey, this is what's going on. This is what, often this is what you think may be going on, but what if we approached it this way?
Right.
What if I told you don't need 10 hours a week? Maybe you need 10 minutes a day, So these little perspectives on time and just changing their perspective just a little, because that'll have I think it has a lot of huge implications.
Funny you say that. I wanted to bring this up. Sarah Dimmick, last time she was on, or when she was on last week, she said something perfect. She's like, I want to make safe sexy, like
Nice.
safe exercise sexy. And I love that because that is, I started to think about it more in our world, manual therapy, pathomechanics, biomechanics, it's so sexy.
Right.
It's like the most sexiest
I do
thing.
this, and this happens. I mean, that's why we do. I got into it for that reason.
Same here, man. Like I heard these words, like I heard paragraphs of information from these people who are very skilled in it. I was like, Jesus, that's a lot of info. Like, how did they learn all this and apply it with their hands? I mean, even them doing the techniques, they have to get in like this stride position and like, and like you hear pops and stuff like that. I was like, whoa, that's super awesome. And in my head, I wasn't like that sexy, but I was like, this is attractive to me.
It's cool.
Yeah, and so like, what's fun?
Mobilize it again. Mobilize it again. Oh man!
But we should make pain science is definitely not sexy. I mean, it's probably the most unsexy thing in the world because it ties back to simple principles. It ties back to like breathing, stress, sleep, diet, health, all this stuff.
Sadly, and just it's honest, but self-reflection, right? I mean, it really puts the ball in the patient's court, and often patients talk about their herniation, their injury, as if it was something else, as if it wasn't part of them.
Right.
When in actuality,
It's inside them.
It's inside them. It's
Yeah.
there. It's there. And I mean, this is on the clip. The answers are inside.
The answers are out there?
The answers are out there and in there. Actually, the answers are within.
Yeah.
But yeah, it's funny. Safe and sexy.
Yeah.
So yeah, we got to make pain science
Sexy.
and basic strengthening like squatting sexy. I mean, although there's some cool new squatting tools that are marketed as very sexy. I forgot the name of
Squat Magic.
Squat Magic.
Holy shit.
If anybody has not seen the commercial, YouTube it.
Squat Magic.
Google it. It's probably on YouTube. Squat Master. It's sexy, man.
Do you ever see any of the posts from this company called Move You?
I've heard of it. Yeah, I've seen some of
guys.
them. I've seen some of them, yes.
So I think one of them is a chiropractor, and maybe with the others a physical therapist. But they're funny guys. They have a lot of good information. But they did the Squat Magic, and they were doing all crazy stuff on it. They basically ended up like using it as a pool noodle by the end. They were like tore it apart. It was pretty funny. But yeah.
Squat Magic. There's some videos, man. 25 minutes.
Oh,
There's
I'm
a whole
sure.
Squat Magic workout.
Oh God.
Oh man, the squat perfected. This is
yeah.
insane, man.
Why don't you just squat? Like if
Just
you
squats to sit down.
sit down, stand up. It's so simple.
Squats are dangerous.
Yeah, they're bad for your knees.
Right.
And then deadlifting's bad for your back.
Right. And you should lie on your back, sleep on your back with your legs elevated.
Arms crossed and just look like Dracula.
No, that's a question we often get.
How do you
should
sleep?
I sleep? Like
With your eyes closed.
No, and I sound like I'm selling a car, but no, it's like, well, however you feel comfortable.
Yeah, you have to be comfortable to sleep.
Yeah.
My God.
I mean, the idea of like,
There's a specific, your vertebrae rotate about 3 degrees to the left when you're on your right side. Your diaphragm is more thick
get
on
that
the
pillow
left side.
between your legs. Again, all
Arm.
of that, if a pillow between the legs or laying on your side or laying on your back, whatever allows you to get a restful sleep.
Right. The sleep is more important than the position.
Yes.
Yeah. So, I mean, we talked a lot of stuff today. So I think the overall theme in terms of the positive spin on it, right? So let's say you're a clinician or you're about to become a clinician, you're graduating. Just keep this in the back of your head. At least understand what's happening in our profession. You don't have to jump in, if you're not comfortable with it, you don't have to jump into a cash practice, jump into an out-of-network practice, or start your own thing to make a difference. But at least understand what is going on where you can talk to other like-minded individuals who are trying to push our profession forward. There's so many people now out there doing that. There's so many avenues to connect. Facebook, Instagram, Twitter. Reach out to them. I've had so many people reach out to us, shadow, and talk in person. I feel like that's the best thing ever. If you guys have negative or positive things to say about what we're saying today, don't comment on Twitter or Instagram about those things.
Contact us.
Contact us. We have emails. We got phone. You want to meet in person? We can meet in person. It's fine.
Yeah.
No, I'm not talking about the band.
No. Yeah, just let's trade ideas. And I think, this podcast
You
should be
went right there.
I had to. I could see Leo like, what? Yeah, meet me in that park. No.
I'm a little guy. I'm only 145 pounds. I'm harmless.
Don't let him kid you. But I think this is a call to action here.
Yes.
And in terms of, please, we would appreciate any feedback and ideas on how to mobilize and to create change. Really.
Yes.
And if we really just focus on a couple of key points here, is how do we optimize patient care, and most importantly, how do we optimize our own care? How do we optimize the delivery of that care? Because often, we may, quote, give quality service, but at what cost, right? The cost is the burnt out therapist. So how do we have a middle ground where the patient gets better, and as a therapist, we can continually provide that service? First patient of the week to the last patient of the week should be receiving the same high quality, innovative, creative kind of approach. So again, we call on the public to send us your comments.
Yeah, and Matt LaLiberty and Dr. Jordan said they mentioned it when they were on last time, but the emotional investment we have with our patients, that's very taxing. It's not a bad thing. We're just saying that's the amount of work that it takes to do an evaluation, to build that relationship. So when we see less patients in a day, we're more adequately able to manage that energy, manage that investment, and pile that onto multiple days in a week. So if you're seeing 16 patients a day, 18 patients a day, that's really challenging to offer that quality care, to offer that great relationship versus 4, I dare say 8, but I think the ideal was 4 a day. That's adequate care, so you can actually give information to the person,
Right.
follow up with them.
But also, as another follow-up is, kind of Lee touched upon it today, but as a physical therapist, as a trainer, practicing what you preach, and most importantly, taking care of yourself. I mean, we use the analogy of the oxygen mask.
Yeah.
When you go into an airplane, they talk about, delivering your oxygen prior to any child that's with you in order to truly help them. So it's the same as in our career. If we don't help ourselves, how can we fully help someone else?
Right. Take care of yourself. Do things that make you happy. Be with people that make you happy and laugh, and give yourself breaks. You're allowed to have breaks. You should take days off.
Use that vacation time while you guys have it.
That's right. That's important.
All right.
Any closers? Do you have any closing comments?
Closing comments? Give suggestions. Let's mobilize.
Yeah.
Let's connect. Let's change the game here. I mean, create our own game. Create our own little system.
Famous quote: people who are crazy enough to think they can change the world are the ones who usually do.
Well, that's a great quote to end on.
So feel a little crazy, and let's get shit done.
Signing off.
Thank you.
Bye.
Thank you for listening to A Few Good Physios. Follow us on Instagram, Twitter, YouTube, and Facebook. Follow us each week while we interview guests and have clinical commentary.